Welcome back to the American College of Surgeons Bulletin Brief from the Front Lines, Surgeons' Voices. With me today is Dr. Haytham Kaafarani, and Dr. Kaafarani is an associate professor of surgery at the Harvard Medical School and at the Massachusetts General Hospital, where he also serves as the director of COMPASS, the Center for Outcomes and Patient Safety in Surgery. Welcome, Dr. Kaafarani.
Oh, thank you, Dr. Wexner. It's a pleasure to be with you.
Thanks very much. The reason we're chatting today, Dr. Kaafarani, is in follow-up to a brilliant lecture you gave during a session that I was fortunate enough to be able to co-moderate with Dr. Mary Brindle from Ariadne Labs in Boston on wellness. That session was specifically solutions to support well-being for surgical teams. And one of the talks in that session, for those listeners and viewers today who haven't yet seen it, was an absolutely innovative, fantastic, compelling presentation you gave about wellness and introducing a wellness program. So I'd like you to expand a bit upon that program, perhaps its inception and what it's meant to do, so that people have a better understanding of what you've accomplished.
Yeah, absolutely. I enjoyed that session as well, and I learned a lot from my co-speakers. But what I talked about in specific, I approached the wellness a few years ago from a different perspective, which is how can we as surgeons support each other when we're in our worst times? And our worst times are usually when we harm a patient, when we have a bad outcome. And so we established about maybe 3.5 years ago, a peer support program, what I call the surgeon as the second victim program at Mass General Hospital. And I'll give a quick overview, and perhaps we can go into more details later. I'm rarely perceived in my own hospital as the touchy-feely guy, if you want. A bald Middle Eastern bearded the trauma surgeon is not exactly the stereotype of the touchy-feely person. But what happened is I had approached it from a study point of view, looking at the impact of intraoperative adverse events on surgeons in the different Harvard hospitals in Boston. And I was purely thinking of it from a research point of view. But then what I got is these pages and pages of volunteered notes by surgeons from all these hospitals sharing their experiences when they felt they harmed a patient, or they had an error or an adverse event to a patient. And when we presented this, my chair back then, Dr. Keith Lillimo, called me into his office, and it's never good when you get called into the chair's office. And I thought what are you doing airing our dirty laundry? But what he said, actually, he shared with me his own story. And he said, well, instead of now doing research, it's about time to bring it up, to do something about this. We need to do something about this. And he challenged me to do that. So what we did is I went through a lot of literature search. I found out some of the pioneer work in other fields that was done. And then we created what I call a 5-tiered approach to it. The first tier was to establish the peer program is, where do you place it? The fear was that it could be, available for lawyers, which we wanted to avoid. So we placed it technically under the QA umbrella of the department, which protects it from litigation. The second one was, how do we identify natural peer supporters? And instead of just doing it haphazardly, what I did, I went to the surgeons and the residents in the department. We made it a little bit like an award ceremony, where who do you go to when you do have a tough case and your patient didn't do very well? Not who do you go to for clinical help, but who do you go to just, a colleague that can support you. And names floated up. And when those names floated up, we told them, congratulations, you've been chosen as peer supporters. And then we the hardest thing was to find a time to do training for the peer supporters. It's hard to get a lot of surgeons and residents in the same room, but we did. And then we had experts come in peer support from other fields as well as ours. And we did a very interactive session of, if you want, case scenarios. And it was very real. It didn't feel fluff at all, actually. It felt really right at the gut of surgeons. And then after that, we established a way of getting the word out whenever there is a an adverse event that happens. And to be honest, the word of mouth is really important. Once your program catches a little bit of reputation, you get multiple sources telling you, did you hear what happened in OR 30, what happened in OR 55? And then you reach out to people. And then we establish the intervention. The first thing we do is I personally send an email with some supporting tools to the surgeon that was involved or the resident that was involved. And it's a opt-out program, which I think is key for anybody who wants to do something similar, meaning I am sending you somebody to provide you support, what we call a walk with coffee. And they have to opt out. They can say, I do not want it, but it doesn't put the burden on them to call you and your phone to ring asking for help. And then there's a very specific intervention and what kind of tools and how we talk, and that's based on the training that we provide to everybody. So that's in a nutshell. And now the program has been up for about 2.5 years, 3 years, and it's going very well, and the feedback has been fantastic.
So it's an excellent program. A couple of questions about the mechanics of the program. Number one, you seem to get your people to put into the support mechanism by word of mouth. Is there any formal mechanism, such as during case review or morbidity mortality conference, to have a selection process?
Yeah, absolutely. So we actually look for every source possible. So the M&M provides some of the cases. So it's very typical that if I'm an M&M and I notice or anybody else in the peer support program, we will activate the program for them. We also we have 100% mortality review. So I have contacts there that will refer cases to me that they could need help. We also look at the individual mortality. So we have the general surgery, departmental M&M, but we also have the different divisions. Big divisions have their own separate M&M in addition. So that's another area we look for. I look at the safety reports that we get. It's not like I screen them, but I have people there who, if they notice something could be of that sort, they refer. But in the end, like I can tell you now, all of these work theoretically, but once you gain traction on it, it's really the word of mouth. I mean, I get anesthesiologists who sent me emails about the topic. I got nurses who do that. So basically, people know there was something. There was a lot of emotional tag to it, and I would get a note, hey, did you hear about this? Can you reach out to such and such?
And what is the length of time that would generally be invested, firstly per session, and then the other question, the corollary, is how many sessions? Is it something that happens for a day, a week, a month? Does it vary?
So for the individual surgeon, we reach out and accepts the intervention. It's the peer supporter finds a time to either talk by phone, and most of the time it's in the hospital, they go get a coffee together and they walk. And it's ranged from as little as 15 minutes of just talking a little bit about it to, I would say, I had one sit which was about a couple of hours, which was a very difficult case. We don't typically build in that we have to be checking a second and a third time, but we do the second and third time depending on the circumstances and how well we feel somebody is doing. The other thing is if the peer supporter, and that's part of the training, they feel like there is a situation happening that needs more professional help, then they refer that surgeon to employee assist program, which has professional psychologists and psychiatrists. And it's happened at least a couple of times. And those were good catches. The peer supporter is a surgeon, is not a psychologist, psychiatrist. So if things are a little bit tougher and they recognize that, we refer them to more formal help.
Yeah, interesting. And you mentioned at the beginning that you asked around, well, who would you rely on when you have a problem, and who do you think could give you good counsel and advice? So you started with a certain cadre of people. So the two follow-on questions are, did any of those peer supporters end up in the situation that they needed the support? And how would you handle that? And then secondly, did your pool of peer supporters increase as people went through the program and were happy with the result to them? They had some major problem where they were the second victim and they went through and felt, wow, that was really helpful. I'd like to give back, and therefore I'd like to be a peer supporter?
Yeah, two great questions. The first one, the answer is absolutely yes. There was many surgeons who were peer supporters who did end up receiving peer support themselves from another peer supporter. So that happened quite a few times. The We did not increase the pool per se, because I mean you need the training. I hate to have somebody just join, and the training takes quite a bit of coordination. We are right now preparing for kind of refresher training, which we will have new people. Some residents have already graduated, so not available anymore. So to get new residents as well as new attendings. But one thing we did is, which we did publish in the Journal of the American College of Surgeons, we did a one-year evaluation of the program in an anonymous fashion, where we sent two surveys specifically to peers as well as peer supporters, and some of them were both peers and peer supporters, so they got both. It was very simple, but one of the questions was exactly what you asked: is if how, I can't remember the actual wording of the question, but it's to the meaning of, do you, like, now that you experience the program, do you want to be a peer supporter, or do you want to continue to be a peer supporter? And the answer was overwhelmingly, like in the 95% of people said, strongly agree or very strongly agree. So the feedback is yes, people who've experienced this, most of them give very positive feedback, and they do want to become peer supporters or continue to be peer supporters.
It's a great program, and I hope people both tune into the session to look at the archived session from Quality and Safety and read the JAX article. The natural corollary question for me would be, your hospital is part of the Harvard system. You mentioned it. Is the program throughout the system? And then there are other hospitals in Boston outside of the Harvard system, let alone other hospitals all throughout the country. Has anyone else come to you to figure out how to implement the program?
Yes. So within the hospital, so the Department of Surgery and the Department of Anesthesia were the pioneers in establishing what we call this specialty specific peer support, because, and I think it's a point worth just maybe 20 seconds elaborating on it. There are peer support systems in a lot of hospitals. The difference is it's very hard for an internist to support a surgeon, or a surgeon to support a radiologist, just because the strength of the program builds on the premise that I've been there, I've been in your shoes, I know how it feels. I can't make you feel better now, but you're not the only one, and you're not alone in this. So when you have an internist telling you, yeah, I know how it is to hurt the aorta and have your patient bleed 24 units of blood, the credibility is not there. So that's why the specialty specific quality of the program is really the value in it. So since we, anesthesia and surgery, we have the first two programs in Mass General, and actually in the Harvard, or if the Mass General Brigham system, if you want. It did get a lot of feedback, a lot of traction, and now the institution has taken at least the Mass General to establish similar programs that are specialty specific in different areas. So we have one that just started for OBGYN. We have one that started for perioperative nurses, and we have one that started for ICU nurses. There is the other surgical departments who are interested in it and are looking. So it is getting leveraged to be at an institution level. Outside Mass General and the Harvard system, there was at least two departments of surgery across the country that have reached out to me and our program here, and they asked for help establish their own, and they have established their own. And I did go and visit them and help with the establishment of the program, and to my understanding, it's working out very good as well.
That's great. So my very last question is, do you have the training that you mentioned templated out, so that if somebody wanted to start a program elsewhere in the country, they could do so based on something, of course, with you or somebody else coming to help launch it?
Yeah, I brought it down from 6 hours to 4 hours now to accommodate. Template is probably the right word to put it in it, but I adjusted it for the two programs where I went outside MGH to fit their culture. After I spend a little bit of time understanding their situation, their culture, their structure as a department. So I tailor it still a little bit to how those departments are structured, but it's pretty much established where there's a 1 hour talk that creates establishes the point and creates the need, if you want, makes people realize and reflect that this is a important topic and it matters to each one of them. And then there's about an hour and a half of uh, lecture style, but it's a little bit of interactive where we talk into the phases of healing that people go into whenever they have a major event like that. It kind of normalizes that, oh yeah, I can see that. I went through that. I went through that. So there's established science about it. So lays it out. And then there's another hour and a half where we go into real case scenarios of real patients. And we pair people into a peer and a peer supporter, and they alternate and they go into how they support each other. And that's where most surgeons, funny enough, discover we're not very good at listening. We want to jump immediately and help. So that's the main skill that we try to teach them, is how to listen and not jump immediately to try to offer solutions.
Excellent. And a very good ending point too. Of course, what is the expression that when you are the one speaking, you're hearing what you already know, and when you listen, you may actually learn something you don't know, which is good to listen. And you're right, surgeons are not always the best listeners. Well, congratulations on having built this really top flight program. And I do hope people take advantage of listening to your excellent talk, reading your article in JACS, and hopefully adopting the program in their local environments.
I thank you, Dr. Wexner, and thank you for the American College of Surgeons. Really appreciate the chance.